Welcome back to the Wellbeing and Practice podcast, bringing you the latest in complementary, integrative, and functional medicine conversations. I'm Tanya Borowski, Head of Education here at Amrita, and your host. Today, I have with me a dear friend and colleague who many of you will be familiar with, Tracey Randell. And Tracey Randell has a specialist interest in GI health and how this sort of fans out to all other aspects of working in an integrative and functional way. And so I am absolutely thrilled to introduce you to her and for you to get to understand how she came into work specializing in GI health and all of the aspects that she has learnt along the way. Welcome to the podcast, Tracey.
Thank you very much indeed. It's an absolute honour to be here today. Thank you very much for inviting me.
Oh, I'm thrilled. So, Tracey, we've known each other a long time now. You and I sort of started off as nutritional therapists. I think we trained in separate through separate education venues, but we sort of qualified within sort of a year of each other. But we met sort of fairly soon after that with a sort of a passion and a quest for more and more knowledge. And I remember meeting you at the inaugural AFMCP when IFM sort of very first sort of launched that course in London, and you and I sort of met over a herbal tea, and we'd literally felt that we'd found our niche, and from there our friendship and our passion for this industry has just grown. Could you talk us through a little bit about what sort of led you to decide to sort of become a nutritional therapist, and how that then, I guess, what sort of journey that took you on to morph into deciding to specialize or have this specialist interest in GI health?
Yeah, okay. So in keeping with a lot of us nutritional therapists, my reason for becoming an NT was purely driven by self-interest.
Yep.
A desire to sort my own health out because in my 20s, late 20s, even early 30s, I I was unhappy with the way that I looked and I felt. I suffered with irritable bowel syndrome. I was somewhat overweight. I was queen of diet books. I had tried every single type of diet from Davina McCall's detox to Carol Vorderman's detox through to the Atkins diet and lots of others. And I put myself on a night school course to do an ITEC in nutritional therapy, which was just a 6-week course. And really what I remember about it was that the recommendations were to eat porridge oats and broccoli and not too much else, to be honest with you. And
Gosh, I
during
didn't
the
know this about
session,
you.
during the sessions, I got chatting with a girl who recognized my interest in the area because my close attention to lots of diet books actually did afford me with a reasonable knowledge, which meant that on my ITEC, I was able to show that I knew about some vitamins and minerals and some other things that I'd obviously had learned through having my nose in these books. But she had said to me, look, if you like this nutrition thing, why don't you do a proper nutrition course? And I said, oh, I didn't even know if it was even possible. So anyway, I in probably within a couple of weeks, I found myself at an open day for BCNH, British College of Nutrition
Yep.
and I got myself into a conversation with Breda Gajsek, who's the principal there, and got talking to her, started looking through some of the course materials. And she said to me, or, are you interested? And I said, well, I don't have a degree. And she said, well, that's okay. You can do a science foundation. If provided you pass that, then I can give you a place. And I just thought, well, why not? At that point, I think it was a weekend every month and a couple of evenings a month to do some study. I was living by myself, single girl, lots of time on my hands. So why didn't I do that? And so that was really what happened. Was I started doing a course and just loved it. Loved it.
Oh,
So, and very quickly, as you know, when you start to learn about diet and nutrition, you then start to practice what you're learning, and started tidying up my diets over the course of, it wasn't an immediate overnight thing, obviously, but over the course of the training, kind of completely changed my thoughts around what a good diet needed to be. And yeah, and things like my IBS disappeared. My weight, I was much better able to control that. And yeah, and so I qualified, and then I did nothing with it because I wasn't really sure if I could make a living being a nutritionist at that point, because I didn't know
yep,
anybody that was a nutritionist that was making, a full living at it at
yep.
that point. So I carried on doing my job. At that time, I was a director of sales for a travel company. So carried on doing that. I was obviously quite senior in the post and had been in the travel industry for quite a long period of time by that time. And then two things happened really. I kind of met and married my husband, and I also changed my job role in my in the travel industry, and I made a big faux pas. I basically made a career move that wasn't a good fit for me, and I was horribly unhappy. And so my husband gave me a gentle nudge and said, "Isn't it about time we did something with that nutrition? Because you're qualified and you keep moaning about losing your knowledge and everything else. And come on, you need to do something with it." I had an opportunity to work for another nutritionist at that point in time who would act as a little bit of a mentor for me. So
Nice.
I just started working for him on Saturdays, seeing some clients that he'd lined up for me. And I just grew in my knowledge and my experience and my confidence over a period of a few months. So eventually, what I did was cut ties from the travel industry and launch myself off as IBS Clinics.
Wow.
So yeah,
So
so
would
that was a
so
2011 now. So
so would you, for a lot of the practitioners listening, and sort of it is a very difficult, it's very overwhelming when we come out of whatever institution it is that we qualify in our first modality as an NT or naturopath. It is very overwhelming to think about, okay, how do I take this passion to be, and with that, what's in our heart and soul, to be healers, but also marry that with having a commercial head to be able to make a living from that. So would you do you looking back on that, do you recommend working for an already established organization, if somebody's, and like you say, use that as some kind of mentor to help to give you confidence and give you rungs on the board to be able, and you've got that support network.
totally, yeah. I think we leave college with our qualification and a head full of knowledge.
Yeah.
We don't really have much of an understanding of how to apply it. We
Yes.
also, I mean, I was lucky because I had been running small implant operations, so I was used to running a P&L, and I had a bit of business acumen. But that's not a typical kind of scenario at all. We
Sure.
all nutritionists come from different kind of backgrounds and whatever else. But so I think, like I said, you're full of all of these ideas, things that you think you want to specialize in, but you've got no idea. You haven't even figured out how you're going to take payment for someone,
No.
or if you need a patient management system and what you should be using and what you should be doing. You actually haven't even figured out how you're going to operate and manage the consultation itself in those instances. So I think an opportunity where you're under the wing of someone else, whether that's another practitioner that's got too many patients on their books and wants to give you a few, and then to act as a mentor
Yeah.
to you. I mean, so much about what you learn is it's just like passing your driving test. It's only when you're out on the road that you learn.
Totally.
When you park in a supermarket car park and you scrape the car next to you, then you know that you've got to be a bit careful and turn the wheel a bit more fully next time you go in. So with nutritional therapy, it's just the same thing where you learn how to talk to patients, you learn how to sell. It's a selling job. What you're selling is you're selling good health, and that it's in little chunks that can be done steadily over time, that the person's going to benefit from taking these recommendations. So you've got to be able to establish rapport with someone fairly early on. They need to be able to follow your thread, but it's only with good experience that you know how to tell the tale, how to elaborate in order to get someone to follow your principles, you know. And sometimes we're better at emulating what somebody else has done. So sitting in with other consultations being done by an experienced practitioner, having someone mentor you, so that you get to talk over a case before you meet the person, and then you talk it through afterwards to say, what did you feel like you did well? What did you think you did badly? You know, what could you learn for next time? Reflective practice, you know, is all important. And you learn on the hoof, and you learn by mistakes, and you're going to make plenty, and that's okay, you know. And the other thing that was always said to me, principal of my college, Breda, always said, if you get stuck, remember, start with food. It's about food.
I love
So
that.
yeah,
And
so
yeah,
yeah, so think about if you're really struggling about, oh gosh, how am I going to start with this person? Look over their diet diary. Make sure you know how they're eating and what they're doing. Find 5 things to take out and 5 things to put in, and have them do that. And then that gives you some thinking time, some research time to come
totally.
up with a bit more of a plan, you know. And also remember that the person, unless you're really super unlucky, the person in front of you does not know what you know. You know, you do sometimes get some people that are internet warriors and that are boned up on a load of stuff, but they will have picked up a load of generic information that they're
Yep.
applying to themselves that might not be relevant. So try not to get, you know, it's kind of, you can get intimidated sometimes by patients that appear to have a lot of knowledge. But if you can start with some of those basic principles, then
I
you will
love
learn
that.
as you go, and that is what happens.
I totally agree. And it is a bugbear of mine that I'm going to, that I feel that the art of nutritional therapy has been somewhat or very much overshadowed by the term functional medicine, integrative medicine, which uh, is, and we have sort of, we've lost that art of our foundational modality, which is food first.
Yeah.
And really we are too quick to try and jump into the biochemistry and not take the time to actually talk about our foundational art, which is food first.
Yeah. Yeah,
Yeah.
absolutely.
So with that, what then led you to, so you're in this career, you're beginning to really gain confidence, you're seeing more clients. What sort of penny started to drop or flags started to be illuminated that led you to go on to study with IFM and meet me? It was like to become best buddies. Anyway, yes, go on. So
Um,
what's have led you to that?
I suppose it was a real hunger to the competitor in me, the salesperson in me, wanted to be really good at what I did, to
Love
be
that.
known for being really good at something, and therefore wanting to know everything I could possibly know first, if possible. And so for me, functional medicine training and IFM and going over to the States married 2 things that I love: travel and learning.
Yep.
You know, so why wasn't I going to go to IFM and try and learn a load of stuff first to kind of bring it back and start using it, and already know about it? When people started talking about it, it's like, yeah, I've done that. I've got the t-shirt on that one. I've done that module, you know. So that was it. It was just a kind of a hunger really for knowledge and to be good at something, and also you get a real rush when you really help someone, you know,
Yes,
when
totally.
someone's, and what I love about working with gut health and irritable bowel syndrome is that, you know, IBS isn't life-threatening, but boy, does it impact on the quality of life that a
Yeah.
person has, you know. So you get people that can't hold down a full-time job because the fact that their bowels are so unreliable that they only want to work from home, they can only work part-time,
Yeah.
or that they just don't have the confidence of being away from home, or and doing things, and they don't want to travel anywhere, and so that kind of, that's self-limiting for them. And also that they feel so terrible most of the time that they just don't feel able, feels like a disability for them. And I've had situations when I've helped patients fill out PIPs, where they've been on some kind of disability because they've been a student that can't do their exams because they're so brain fogged because they've got poor gut function, or they've got other issues with gut health and beyond, and that's been a kind of a terrible way to live. And so when you can help someone and you can give them a quality of life back and they can go and do what they want to do, then I think that's the biggest rush of all, the biggest high. So that's what I've really loved about doing what I'm doing. And I think that's why I love gut health so much, is that I always describe the gut as being the engine room of the body. We know, don't we, as nutritionists, that nothing that you're going to try and do for a patient is going to work if they can't digest, absorb, and assimilate and detox properly.
Yep.
Then it's all for nothing. So the gut is for the most part is the starting point and the most important thing to get right when you're working with someone, which is why I kind of settled in that kind of area. And obviously
Love
irritable
that.
bowel syndrome was something that I had experienced myself. My mum had a history of inflammatory bowel disease, so that was also another kind of keen interest.
Yeah.
So, and then after that, my specialisms found me, the patients that came to my door.
That definitely happens, doesn't it?
Yeah.
And so you were one of the first in the UK, I think maybe even first, to really start talking about SIBO.
Yes.
Yeah, you were, and that, like all aspects of, or all, yeah, like many aspects, if you like, has evolved. And so I'd love to talk about that in terms of sort of how this came about, and also where we are now in terms of how you approach that, and the way that you view it, because I think it definitely has evolved in the way that we think about it and the way that we approach it. So first of all, could you explain what SIBO is and how you, and then sort of let's go on to sort of talk about sort of how you have seen this evolve and what sort of lens you frame it in.
Okay, so SIBO stands for small intestinal bacterial overgrowth. It's a frank overgrowth of bacteria in the small bowel.
Mm-hmm.
We're all used to thinking about gut microbiomes, friendly flora, probiotics, but most of the time we're referencing the large bowel domain. And it's important, I think, to understand that the small bowel has a very different function from the large bowel. The
Mm-hmm.
small bowel's job is to continue, well, most of the small bowel, its job is to continue the process of digestion, which arguably starts before you put the first bite of food in your mouth. But let's say you swallow your food, it goes into the stomach. When the food leaves the stomach, it then arrives in the upper part of the small intestine, the duodenum. And as the food progressively moves through the small bowel, it gets more and more digested and broken down. Then it crosses through the ileocecal valve into the large bowel. And SIBO is a term that references extreme bacterial overgrowth in the small bowel where it has no business being. So usually the small bowel is somewhat sterile. Certainly the first third of the small bowel is somewhat sterile because it's bathed with digestive secretions, so stomach acid coming from the stomach, bile, and digestive enzymes that are all quite effective disinfectants that will discourage bacterial growth, keep the bacterial population down. Obviously, the longer the distance from the stomach, and
Okay.
as the food gets progressively more broken down and travels through towards the ileocecal valve, the bacterial population in the latter part, the distal end of the small bowel, increases. So it becomes, a bit more in keeping with what's in the large bowel. But what happens when the bacteria overgrow in the upper gut is that the bacteria come into contact with your food. And more importantly, certain aspects of your food. So carbohydrates, in particular, fermentable carbohydrates, become fodder for bacteria. The bacteria in there metabolize, break down the FODMAPs, as we've come used to calling these foods. and they create gases. They usually create hydrogen and methane gas, and we also know that there's a third gas, hydrogen sulfide, that gets produced in some instances as well. And these gases influence how the gut moves, what the motility of the gut looks like. And also there are some symptoms that are associated with each particular type of gas production. In this kind of SIBO patient, I'm calling it kind of SIBO because as time has gone on, the way that we term SIBO is different. So SIBO now really relates to hydrogen or hydrogen sulfide production, and now the methane production that we used to call methane SIBO or IBS-C is now IMO, intestinal methanogen overgrowth. And we're also using ISO, intestinal sulfide overproduction, as well as being a term for hydrogen sulfide SIBO. So there are three types of SIBO, the different gases caused by different bugs that have varying influences on the way the gut behaves.
Nice. Okay. So, sorry, carry on.
So all I was going to say is that's how I'm used to kind of obviously describing it in clinic with patients. And I guess one of the points that you made earlier on was like how things changed. Well, back in the day with my first SIBO cases, I swear they were quite simple.
Yeah.
They were hydrogen types. We didn't even have a FODMAPs diet then. That kind of predated the FODMAPs diet. So we used to use the specific carbohydrate diet and some antimicrobials and some probiotics, and people got better and didn't see them again. They were fine, Now kind of fast forward 14 years on, I would say that SIBO is a gut dysfunction that we readily recognize. We can pick it up very quickly from someone's clinical background and history and symptom picture. And we test, and most of the people that I test for SIBO have SIBO. We very rarely get that wrong. I have a good nose for it these days. But the thing that has really changed is what goes alongside the SIBO. It's the understanding that SIBO is existing because of other things that are happening with the patient. And I've come to understand that SIBO is the thing that is easily recognizable, but the reasons for its presence vary enormously. And so for a lot of people, their SIBO is, poor history with things like stress management, terrible diet for periods of time, antibiotics, various anxiety profiles. So all of those are kind of predisposing factors. Sometimes you get a very obvious case of SIBO, which might be post-infectious. So someone will say, oh, I went on holiday to Ghana, I got a bug, I was ill for a few days, and then my gut's never been the same since. Well, that's easy. That's a post-infectious SIBO. I know how to work with that. And I would say also that the hydrogen type of SIBO is relatively straightforward to get on top of. What I'm seeing most often, though, are methane and hydrogen sulfide. So methane is the one that I'm seeing very much at the moment. And I'm seeing methane and I'm seeing histamine intolerance alongside that picture as well. And with that kind of picture, there's a much bigger story that's going on. And it's so important when you're working with methanogen overgrowth, you have to work in the entire gut environment in order to get that person well. And that is a much, much bigger picture than just dealing with antimicrobials from someone that's just got a bit of hydrogen SIBO, because you've got to dig deep into how someone's eating, get them to kind of transition into a more healthful diet and know that they've got to maintain it. Otherwise, this situation's not going to resolve. It's just going to come back. The SIBO is known to be able to rebound super readily.
Yeah.
And it will rebound really readily if the person has not made the changes to the diet that you've recommended. And sometimes a person with methane is so sensitive they can't take prebiotics. So you've got to go super low and slow, look at the bigger picture, see if what else you can kind of calm down first, before you can even start working with the main event, if you like. So that's what I've learned is different types of SIBO, the fact that it's often part of a much bigger picture. And it's also, I guess, it's made me adjust how I talk that back to patients and the type of guidance I give to patients these days. I used to say with hydrogen SIBOs always, 2 or 3 months, should be sorted. When you've got someone with a methane type presentation, you know, you could be looking at 8 months, a year and a half, depending on
Of
how
moving
well.
forward and taking a step back, moving forward. Right. So it's
Yeah,
a lot of this
absolutely.
is counseling of expectations.
And it's managing expectations as
Sure.
well, you know, because patients often come to nutritionists when they have exhausted mainstream medicine and everything
Uh-huh.
mainstream medicine has to offer them. And what we know about GPs is GPs do their very best to help, but they have a toolbox which is full of medications which suppress symptoms. So there's a value to using some of those things,
Yes.
absolutely, but they don't address the underlying causes. That's where we come in. But patients have kind of got this message that they don't, it's not their fault that they've got a condition, that they don't need to do anything about their diet or their lifestyle or anything else. They just need to take a pill. So sometimes when they first come and work with us, they think we're just going to give them a probiotic instead of an antibiotic. And we might twiddle around and, you know, with their diet a little bit and tell them to eat more oats and eat a bit more broccoli, but they're not really expecting us to do too much more than that. And so that can be a bit of a shock. And so sometimes you can get people that will start working with you and then just give up because they didn't realize that they had to work so hard and work for so long. And they, you can tell the people that start to lose a bit of heart sometimes because they'll say things like, how much longer do I have to be on your diet for? Or how long have I got to be on this diet for? And it's like, no, this is a way that you need to behave for life because you are where you are because of everything that's gone before. So yes, some of these things, these stressors, these other factors that have come into your life, there's nothing you could have done about those. But because they've happened, we have to now make sure that you eat in such a way that we can nourish and support your microbiome, because your microbiome is asking for help. That's the SIBO presentation. That's what it's telling you, you know. So
Okay. Yeah.
these are the messages that I've learned over 14 years. And these are
Thank you.
what I explain to my patients when I'm working with them.
So you talk there about, or you talk about that the landscape, the environment has changed, that you say that patients have become more complex, and I absolutely observe that. It could be, however, because you've become more experienced and more, as you said, when people gravitate towards you, you put that out into the universe, and those clients come to you. Um, but with that, which either which way resonates with our listeners, if I could just circle back to a couple of points, but also to highlight that Tracey and I are in discussions about a masterclass later in the year to really take a deep dive into the this more complex approach to GI health. Um, but you talked about how there this landscape has changed, and have you seen a difference in client presentation since COVID, since with sort of vaccine injury, with post-COVID infection? Have you seen a direct correlation to more complex, more complexities walking through your clinic door?
I'm sure, yeah, absolutely. What I've seen, what's really interesting on my health questionnaire at the moment, there isn't a question that says, have you had COVID? Have you had any COVID vaccines? So I always ask the question now when I talk to people. People don't think to mention it any longer,
No.
but it's part of their background and their history when you're looking for insults on the gut, you know. So I'm going through their background and they're, yeah, sure enough, they had antibiotics because they had an ear infection as a child, and then they were on the contraceptive pill when they were at uni, and then they had the typical uni diet, which was, you know, lots of starches, lots of beer, um, you know, and then kind of stress as they moved into their first job and all those types of things. And then you start talking to them about other treatments that they've had. Have they had antibiotics for acne, and have they been vaccinated, and have they had COVID, and how many times they have COVID, and what kind of COVID experience did they have? So I've kind of gotten really used to kind of that line of questioning. And the thing that I'm seeing lots of is histamine related conditions.
Yep. Okay.
So I'm seeing lots of SIBO. So what we know about COVID itself, COVID the infection, and also COVID vaccines are
Yeah.
that it tends to shift the microbiome to favor the growth of opportunistic organisms over our regular friendly flora, if you like. So things
Hmm.
become skewed. Now, if you were unlucky to have a kind of a skewed microbiome at the time when you contracted COVID, you are likely to have a worse experience of COVID. You'll have a more extreme COVID reaction and response. And equally, if you were in better health from a gut perspective when you caught COVID, you might be one of those people that didn't really even notice too much that you had it. But in any event, post-COVID, a lot of people's gut microbiomes have shifted. There is definitely a shift. And there is an increase, I think, in histamine-related conditions. And what I mean by that is histamine intolerance, for sure. And in more extreme circumstances, MCAS, you know, so
Yeah.
so histamine intolerance is more a situation where someone has too much histamine and can't clear it down effectively.
Hmm.
They respond quite well to a low histamine diet, in my experience. Whereas MCAS, I think, is more of an immune system problem.
Yeah.
Is much more multifactorial. Then you're starting to look into why is the immune system unhappy. You have to look at stressors, you have to look at vagal tone, you have to look at mold, other infections, and look at the much bigger picture. And I guess I'm doing quite a lot more of that, a lot more
Yeah.
of asking questions around mold and mycotoxins. So that's kind of, I was doing a bit of that before because I tended to attract a lot of Ehlers-Danlos syndrome patients, and obviously,
Yeah, I remember.
yeah, POTS and histamine intolerance was part of that, and MCAS was part of that already. So I was already familiar with that. But then on the advent of COVID and the first kind of long COVID patients, then we started seeing a lot more kind of histamine stuff going on.
Thank you. That's really illuminating, and we definitely will dig into that later in the year. So that's really interesting. So, to round what I think the other aspect of what you talked about, which I know our listeners will be really keen to understand, is the area of testing.
Mm.
When we're, and let's zone in on, or let's hone back in on SIBO, but bring in sort of these different subsets like IMA, exactly. How do you go about, so absolutely, you said you have a nose for it, so signs and symptoms, that it looks very likely that there is a significant dysbiotic tube.
Yeah.
uh, and what level of testing do you do, and how efficacious is it to test those three gases?
Okay, so because of the fact that my company name is IBS Clinics and I'm attracting IBS patients,
Yeah.
most people that present with irritable bowel syndrome, I am going to want to rule in or rule out SIBO.
Okay.
So I will do some form of hydrogen breath test in order to identify whether SIBO is present. I also have patients that are using food marble. There's quite a lot of patients out there that have already bought themselves a food marble. So in which case I can use that data to ascertain if someone has SIBO, has small intestinal
Okay.
bacterial overgrowth. So testing in the UK at the moment is limited really to looking for the presence of hydrogen and methane.
Mm-hmm.
We don't test for hydrogen sulfide very readily in the UK. There is actually one place that people can go to get hydrogen sulfide testing, which is the Functional Gut Clinic in London.
Mm-hmm.
And I used to think that I couldn't wait for hydrogen sulfide testing to come in, but I have to say these days I'm not too worried about that at all. I actually have like a little symptoms checklist that I use to just determine whether hydrogen sulfide might be a thing for a patient. And that works really well alongside quite a lot of my patients when they first come and work with me. If they have the budget, I will recommend that they do some form of stool test.
Okay.
And on the stool test, I'm looking for hydrogen sulfide producers. So bugs that are able to make hydrogen sulfide under the right set of circumstances.
Mm-hmm.
So I kind of use that and obviously the patient experience, patient symptom picture to identify whether I think hydrogen sulfide is a thing. And if someone does a hydrogen breath test and it shows good levels of hydrogen and methane, then I really feel that hydrogen sulfide, if it's present, isn't dominant. It's not the dominant gas. And also there's a very particular hydrogen sulfide, SIBO is very much related with urgency. So people are going to present with diarrhea. So that's basically it. So, and if people are presenting with diarrhea, it's either hydrogen or hydrogen sulfide. If it's the opposite, if it's a constipation, a slow bowel, then I'm really thinking that it's a methane kind of picture. So yeah, so I'm kind of cool on the hydrogen sulfide testing. I think at some point or other there'll be an enterprising lab that will be able to do it. At the moment, what I understand is that hydrogen sulfide gas is, well, number one, you need an awful lot of it because you have to measure parts per billion rather than parts per million, which is challenging because it means you've got to capture very large breath samples, and also that it doesn't travel well. So that's the reason why we're not sending test samples over to the United States in the way that we've done before with almost every other type of test. It's just because the test isn't valid when it gets there. So I'm fine with that. So that's all cool. So for most part, if you come to me with IBS, we'll do a SIBO test, and if we can do some form of microbiome test, then that makes me happy too. So the types of microbiome tests that I like, I've come to realize that a lot of the stool testing that we do is really involved around looking for pathogens, and it tells us much less about the beneficials, our friendly probiotic flora and what they look like and what the balance of those are. So I've started to combine very often a test that's good at looking for pathogens. So some kind of GI map or a GI ecologics or a GI effects, with some kind of biome site test. And then very recently, I've been working with In Vivo with their new Meta Explore biome product that has just arrived in the UK. And that's pretty exciting. That's pretty interesting. That's a good kind of marriage of looking for pathogens and then also looking at the good guys and what you can deduce from that.
Wonderful.
And it's encouraging I don't know, it's really stirring up my thought processes at the moment because the research and the recommendations around that are very much about a more softly approach when working with the gut, looking at supportive nutrients, prebiotics, working more heavily with diet in a more intense way than we might have done before, in order to achieve hopefully permanent changes to someone's diet and therefore a more robust and consistent balance of microflora for the patient,
rather than going in with the traditional
kind of slash and burn type of. I think what I'm playing with at the moment is when to do what. So when a patient is exquisitely sensitive to prebiotics, what does that mean? What else is going on then if they can't even if they can't eat a bean without bloating? What do we do first? Is that about calming the immune system down? Do we work on the diversity of their diets in the first instance? Or does it indicate that actually there is a overgrowth of something that they would do better at, doing some eradication for a short period of time before then starting to broaden out their diet? So I'm playing with all of those aspects of them, which I think is very exciting, and it's odd as a practitioner. You fight really hard to get really good at doing something, and then you just get to a point where you feel like, no, I've got this now. I know how to do this.
I know how you feel.
And then things shift, and then you're thinking, gosh, have I been doing it wrong all along? And it's like, no, you haven't. It's just that there's just another lesson.
It is. I think it's a level of
other learning and understanding, and I also believe very much like the universe is sending me a new subset of patients that I might not have seen before that have got to be dealt with in a bit differently, and that's how you learn everything. So yeah, and I think the new types of testing is very exciting and very intriguing, and we will all adopt those for a while, and before we will shake it all down, and then we'll figure out what suits what type of patient the best, and we will we'll go again, and before something else will come in and disrupt again. And that's just the nature of the job that we do, I think.
It is. And I think for those of you listening, I don't want you to, Tracy and I've been in these trenches for a longish time, I don't, and what my take on what you've just said, Trace, is I have this vision of, bear with me here, but like plaiting, weaving or plaiting a rope, is that actually we keep gaining, and we have this quest for knowledge, and we learn protocols and we learn approaches, but actually what experience brings is, and the desire for to continue to grow as practitioners to better help our clients, is that we learn something new, and we can maybe unravel that rope a little bit, but we're continually weaving in aspects of what we've learned to suit that particular client. So your client that you're saying is what actually, okay, so what is going on with this person that is just so seeming intolerant that they can't eat a bean without bloating, is, and they've tested positive, let's say they've tested positive for methane SIBO, whereas when we first learned about this, we go, okay, we know what to do. We've got the protocol for methane SIBO, but we maybe just take a breath and we say, okay, well, we actually need to unravel that rope a little bit and bring in aspects that we've learned about other components of how the body operates, to build those foundations to allow them to move through removing the methane. Or maybe do we not need to do that if we support the microbiome? But it's being open to continue to learn, and maybe approach things, shake things up, as you said, and approach them in a slightly different way, where we've been taught we have to do it in this order.
Yeah, exactly. It's the moving away from, it's the understanding that a protocol is not a fixed thing, that you don't put everyone through the same protocol. Is a protocol, I still like protocols
I know you do.
because they, well, I consider it like they're a framework.
They
So
are.
for me, a protocol is something that I think through, and I think, okay, do I think
Yeah.
this fits this person? No, not completely. I think with a bit of twiddling here, or I might adjust this here. This bit's not applicable because of X, but this bit could be. Let's give,
Perfect.
yeah. So I think that's what. So a protocol probably is the wrong word. I like the kind of the framework.
Framework is a great word, because we all need a framework, but it
Yeah.
is, yeah, being able to, if you like, push those boundaries and to flex that framework to suit the client that's in front of you, to say what aspects of that do I want to be able to use, and that makes sense. Okay, so you have been so amazingly generous with your knowledge and with your giving away your intellectual property, really, that has made you the most accomplished practitioner in this area. And I am just so grateful, as I know our listeners are, for you to be giving us a window into your clinic room and your amazing brain, and really look forward to welcoming you back to the Amrita family to delve even deeper in a masterclass later in the year. And any client that is listening, hopefully you are already on Tracey's website. So IBS Clinics is where you can find this amazing woman, and she will be able to support you in your health journey. And I look forward to working with you again in November, Tracey. Thank you so much for coming here and talking to us and sharing your knowledge. It's been an absolute joy.
Oh, it's been a pleasure. Thank you for the invite.